Thanks again for the organizers for inviting me to come to this beautiful city. And thanks to all of you for attending on a beautiful Sunday morning when there are certainly other things to do. I've picked things I liked for the year in review and clinical advances. Because there's so many things to talk about, I finally decided, as I'm reading dozens of papers, I'm going to talk about what interests me in these papers. So if I haven't picked your favorite breakthrough in 2012, 2013, please step to the microphone afterwards and tell us about it. So the first thing is I want to be sure that you don't leave the meeting without knowing that there are new criteria for classifying patients as having SLE. Dr. Petrie talked about these in detail. Yesterday I'm going to show you again for the purpose of repeating. The new approach is that you must have criteria in the clinical realm and criteria in the immunologic realm. So you have to have at least one of each. And if you have 4 of these criteria, then you definitely have SLE. And I have put for you in blue here, in these blue colors, the new things. So now, under the clinical, skin's divided into acute or subacute cutaneous lupus and chronic cutaneous lupus. Alopecia has been added. It wasn't present before. Under renal, biopsy has been added. It wasn't part of the former criteria. Isn't that interesting? Under neurologic, the manifestations have been expanded to include mononeuritis, myelitis, peripheral or cranial neuropathies, and acute confusional state. And these cytopenias, instead of all being in one criteria, so you only get 1 point if you have all 3 of them, have now been divided into their individual hemolytic anemia, leukopenia, or lymphocytopenia, and thrombocytopenia. So it's a little easier to score more points than it used to be. What have been eliminated here are malar rash, discoid rash per se. It's now any chronic cutaneous lupus. Photosensitivity has been eliminated, and urinary casts of any type have been eliminated and replaced up here with the red blood cell casts. So that's the clinical, and I know I'm talking to the lupus group because nobody else would care about these details. In the immunologic area, there have been 2 additions. One is low serum complement, very important addition, and something we all use, but they haven't been part of the criteria, and a positive direct Coombs test for antibodies against red cells. Any 4 of these, as long as there's one in each of the categories. Lupus is the diagnosis with 93% specificity, 92% sensitivity, which is really an outstanding set of criteria for classification. There's one other caveat, and that's if you have, you see I put double asterisks here around biopsy. If all you have is a renal biopsy that couldn't be anything but lupus, according to the pathologist, the diagnosis is lupus. You can classify that person as having lupus. These are intended for classifying patients to go into studies, but I don't know about you, but I use them in clinical practice to help decide if somebody fits criteria for lupus. Now, these are the other questions I'd like to address that push us a little more toward therapy. What's the ongoing story with belimumab? Can we prevent lupus in predisposed people? What about glucocorticoids in lupus? Can we get away with lower doses? Are there safer ones? And can treatment be effective without glucocorticoids? Are multiple targets better than one in the therapy as opposed to targeting just B lymphocytes, which I'm going to talk about a lot? Can we target single organ systems other than the kidney? And would that be a good strategy for our subsets of lupus who have arthritis or dermatitis? And finally, can we prevent damage? So when we think about the therapies and our targets in lupus, we know, as Dr. Pisetsky has so elegantly reviewed, that innate immunity is quite involved in the pathogenesis of lupus. And of course, we've known for a long time that adaptive immunity is making many of the autoantibodies that fix complement and cause disease. So ideally, we'd like to have maybe therapies that can target both things. And we have one that does, and it's called glucocorticoids. And that's why we spend a lot of time on talking about how to get the doses low, because they are very effective on both these arms and other arms. Hydroxychloroquine, as you've just heard, targets primarily innate immunity, and most of our other therapies target adaptive immunity. It's mycophenolate, cyclophosphamide, azathioprine, rituximab, and belimumab. So there may be something new down here that would target both, and I'm going to get to that a little bit later. So let's talk about the cell of the year, and maybe the last 5 years, which is the B lymphocyte. And I'm sorry, this is just published in the New England Journal of Medicine. It was embargoed on the day that I made this slide, so I don't have a high definition slide, but it's replaceable now. Here is the B cell coming out of the bone marrow, becomes various levels of transitional B cells, and here this red receptor means it depends absolutely on the presence of BLyS or BAF, which are the same thing, for the cell to survive and to proliferate. The transitional cell then matures toward a naive B cell, also dependent on BLyS, and the B cells enter the germinal tissue and they become follicular or germinal center B cells or marginal zone B cells, and most of these cells are also exquisitely dependent on BAF to survive. And then they mature to activated B cells, and they go either to memory B cells, which have, no receptor for BAF, or plasma cells, which have receptors for BAF. And here in the orange, it means the cell has receptors, but it's not absolutely dependent on BAF. Notice here that helper T cells have BAF receptors, dendritic cells have BAF receptors, and I told you the plasma cells have BAF receptors. All these cells, the transitional cell, the naive B cell, and particularly activated B cells and plasma cells, are elevated in patients who have SLE, and if you bind soluble BAF, you reduce these cells that are elevated in SLE. So here are the combined results of the belimumab trials, and I note with pleasure that in Dr. Navarra's paper, which is BLyS 52, there are several Latin American co-authors, and I noted Alberto Galicher here, who is from Buenos Aires, and there are probably more. So here are the results of the trials, and the results here are combined. The response that was defined as this combined response index, SRI, 39% in placebo, 51% in belimumab. So not huge response differences, but highly significant in the combined data from both trials, which were published by Dr. Manzi. Here are the other effects of belimumab that reached statistical significance: reduced severe flares, increased the percent of patients who had their prednisone lowered to 7.5 milligrams or less, increased function on the SF-36, reduced anti-DNA and total IgG, and increased complement. So these are the benefits of belimumab. Now, in the past year, we have learned a lot more about how to use it. First is, we have learned who the best responders are. The best responders have high activity, SLEDAI scores of 10 or higher, positive anti-DNA, low serum complement. That's your target group for the best response. We've also learned the response is durable, and I put all the authors at the bottom. This author is Merrill. Among 296 patients followed up to 4 years, the majority maintained improvement in their SLE. It was well greater than 80%. So this is a durable response if you continue therapy. Nephritis may benefit, and of the two BLyS trials, 267 patients were enrolled who had nephritis. It couldn't be active severe nephritis. That was a contraindication. But if it was just puttering along and you had another indication, you could go into these trials. Over 52 weeks, there were trends toward improvement in the belimumab compared to the placebo, especially in the group where belimumab was combined with MMF. And those trends, and some of them reached statistical significance. Proteinuria reached statistical significance. Flare of kidney disease and renal response to the treatment all came close to significance. So at least we can say that we can use belimumab safely in patients who have nephritis. Quality of life improved both in the physical and in the mental components. Here are the adverse events. They were not different in the placebo group, and you remember the placebos were on background therapy, mycophenolate often, and prednisone, and often hydroxychloroquine. So serious adverse events were similar in the two groups I've shown you here, 17%, 18%. I've chosen the 10 mg per kg belimumab because that's what the FDA approved. Serious infections weren't different. Malignancy rates weren't different. Mortality rates weren't different. Look down here, however, here we have a difference. Serious infusion reactions are twice as common in the belimumab group. So here's my personal experience. Roughly a third of the patients I've treated have had definite improvement, although nobody went to a SLEDAI of 0 that they sustained for 6 to 12 months. A third of the patients discontinued, usually for some type of an adverse event. And a third, nothing happened. They didn't get better. They didn't have side effects. And I have the policy of discontinuing it if there isn't any evidence of response at 6 months. Caution, suicidal thoughts and behaviors may occur, and this was reported in BLISS 52, not so much in the BLISS 76. I had 2 examples of that in my practice. And I think if you have a patient, you should screen for suicidal thoughts before you decide you're going to put them on belimumab. Just my opinion. Infusion reactions usually occur on the first or second dose, and if you want, you can give medications to try to reduce infusion reactions. If you get past 1 and 2, generally you're safe, although some late reactions have occurred. Speaking of B cells, let's talk about this phase 2 trial reported by Wallace and colleagues with epertuzumab, which is an anti-CD22. We've heard about that at this meeting. Look here where I've put the blue arrows. The placebo, about 30% of people improved. This is only a 12-week trial, as opposed to 51% on this dose. These are increasing doses here of epertuzumab, and 41% on this dose. And notice, apparently, you can give too much. This very high dose epertuzumab didn't have improvement like these 2 groups did. This is only at 12 weeks. If this holds up, it's faster than belimumab. Phase 3 is on the way, and watch for it, and we'll hope it's as good as it looks in this phase 2. Now, I want to talk just a moment about T lymphocytes as the target, and I want to take this little detour into the abnormalities of cell activation that are characteristic of B and T cells, have to do with increased calcium flux, and Dr. Pasetsky mentioned it. So one of the results of the increased calcium flux and the abnormalities of signaling is that you get hyperpolarization of the mitochondria, which has been pointed out by Andres Pearl. And it turns out that mitochondrial hyperpolarization occurs under oxidative states, which of course are very important in inducing vascular damage in atherosclerosis and tissue damage in the kidney, etc. So if there's NO exposure, or if GSH, glutathione, is depleted, then we have a pro-oxidant state. Glutathione is an antioxidant. So this is the usual situation in active lupus, and even in inactive lupus where it's not so severe, still there. When mitochondria are hyperpolarized, then there's biogenesis of proteins, and mTOR is activated. You remember that's a target of rapamycin. And if that happens, then T cells go toward Th17 and away from regulatory T cells that express FOXP3. So there's been interest by Sokas and Pearl in introducing rapamycin again as treatment for lupus and lupus nephritis, and there's some early studies indicating we should look at that very carefully. That binds mTOR. And here's an expensive way to do it that Anders reported recently in ANR. If you give N-acetylcysteine, which you can buy at the health food store, you can prevent mTOR activation. It restores glutathione is what it does, and you don't get mTOR activation, and the cells can make FOXP3 T cells and become regulatory. Here are the data. in the paper that he published. Compare here this kind of turquoise line, which is the placebo group, to this purple line, which is the group that got the highest dose of N-acetylcysteine. And this is the SLEED eye, and you see it doesn't change in the placebo. See it go down very nicely. And then they stopped NAC here, and you see the SLEED eye score come up again in this NAC group. This is fatigue. Look here at the purple line going down, and it comes back when the N-acetylcysteine is stopped. So this is not approved, but it is available, and if you're interested, you might want to look at it. It can be nauseating. Let's talk about innate immunity. Let's go back to the favorite topic at the meeting, hydroxychloroquine. So I posed the question, can you prevent lupus in autoantibody positive people if you give hydroxychloroquine even when they don't have symptoms? So here's the evidence that might be true. First of all, Judy James in 2007 showed the onset of lupus diagnosis was delayed in people treated with hydroxychloroquine as soon as the physician knew they had autoantibodies. And it was a year until they got lupus, as opposed to 0.3 years for those who had autoantibodies and did not take hydroxychloroquine. Highly significant. These are all statistically significant. Here's a study from Broder and Putterman. Antiphospholipid antibodies were less likely to persist in lupus patients who were treated with hydroxychloroquine than those who weren't. And finally, the study that Dr. Bayan referred to, maternal use of hydroxychloroquine reduces the risk of recurrent anti-SSA-Rho-associated neonatal lupus cardiac disease. So all of these show statistically significant differences favoring using hydroxychloroquine. And I favor it. My answer to this question, can you prevent it or delay it or make it milder with hydroxychloroquine, would be yes. And I do it a lot in the clinic. Now, to keep you up to date, here are the published work with Dr. Petrie as first author on sifalimumab, which is a human anti-interferon alpha monoclonal antibody in patients with lupus. This is only phase 1. So the placebo is, I think, the dotted line here. Yes. And the antibody is this line here. And this is combining several different doses of the antibody. If you just look at the SLEED eye score, you see both groups get better and they aren't different. But if you look down here, what they've done here is do a statistical adjustment for people who got pulses of steroid treatment for flarelets during the weeks of this trial, which is, I think this is 6 months. And you see here, this is the group that got the antibody, and they clearly had more quiescent disease activity than the people who were getting placebo. I don't understand the statistical adjustment, and I'll have to figure out what that was. But it's certainly enough here to indicate we need to go on to study this. Now, suppose that we could find something like glucocorticoids that was safer, and it hit both of these arms here of the immune response, and our group has been interested in laquinimod as the question mark, and could we put it in there, and let me show you what we know about it. Oh, before I do that, let me address, can lupus nephritis be treated without daily steroids? So you heard a talk by Elizabeth Lightstone from London. She's heading the Rituximab study, which has just started. The plan is, this is lupus nephritis. She's a nephrologist. Rituximab 1 gram on days 1 and 15 like we do. Methylprednisolone 500 days 1 and 15 like we do. And then MMF starting 500 milligram BID, increasing to a gram BID for 2 years. And so this is the treatment of lupus, and the only steroids are these 2 pulses. This study will compare this regimen to Cellcept plus daily glucocorticoids. It's prospective, but it isn't double-blind. And it's coming, it's been funded. So that's going to be very exciting to watch. Here are results in the first 50 patients that she published. Complete response of the renal disease at 1 year, 52% with Ritux London, I called it. And the LUNAR study, only 26%. Partial response, a little better with LUNAR. Overall response is better with the rituximab approach without the steroids than in the LUNAR approach, but these are different populations, and we'll just have to watch and see what happens. But the exciting possibility that we can manage people with severe nephritis without steroids is really exciting. Now, I did ask Liz, what are you going to do with people that have 20 swollen joints and active rash and oral ulcers? And she said, I'm going to send them to rheumatology. So we may not be able to totally avoid steroids like she would like to do. Thank you. Now, here's another steroid paper that I thought was fascinating. Someone has invented a dexamethasone prodrug. I was so excited that I realized I don't know what a prodrug is. So this is the definition from Wikipedia that knows everything. It's a form of a drug that reaches its target cells before it's converted to its active form. Thus, it impacts on the target cells where the effect is needed with less systemic adverse effects. And there are lots of them on the market. Lots of the anticonvulsants are prodrugs, and very many of the antivirals for HIV are prodrugs, and they aren't activated till they get inside mononuclear cells. So what a great idea this is. This is what the prodrug looks like over there on the left. See, extensive, this is, of course, you recognize the glucocorticoid chain, the steroid rings, and here is a very extensive side chain that has something to do with acrylamide, and very extensive here, and it doesn't do anything in the circulation and the liver pass. Here is administering it over here to BW mice that get lupus nephritis. Here's proteinuria and the controls. Look at the proteinuria here, how effective. Here's giving dexamethasone, not a prodrug, also very effective in lowering proteinuria. And here's glomerular size. It goes up when disease is bad. I'm going to show you that in a minute. And here you get lower size of glomeruli with dexamethasone and with the prodrug. But the prodrug is safer, and here's the evidence for that. The dark black bars here are the prodrug. These are animals that got hypertension during treatment, and look how little that is. This is bone density, and here is in mice that don't get any steroid, dexamethasone prodrug, much less loss of bone. Here is trabecular loss, and look at it, it doesn't happen with the prodrug, and it happens with dexamethasone. And over here is IgG, which goes down with dexamethasone. It doesn't go down with the prodrug, and the prodrug doesn't affect anti-DNA, but I showed you that it protects the glomerulus. It's localized primarily in renal tubular epithelial cells in the kidney, but it's also in 80% of cells of the spleen, so it's in mononuclear cells. It significantly reduces the number of macrophages in the renal tissue, which is critical because they are major arbiters of damage that occurs in the kidney in lupus and many other diseases. So let me come back to what I wanted to tell you about laquinimod. The advantage of laquinimod is that it affects both T and B lymphocytes in a disabling way, and it affects macrophages to make them anti-inflammatory. This is what it looks like. Let me put up the one you know down here. On the lower left-hand panel here, this is hydroxychloroquine once again. And this is what laquinimod looks like, and you see it's really quite different. It has this basic, and it looks like linamide, which was developed by the pharmaceutical industry to be anti-inflammatory, but it's too toxic to use, so they derived a laquinimod out of linamide. This is ciprofloxacin, Cipro, which you use as an antibiotic all the time. It's also a quinoline, and of course it behaves completely different from hydroxychloroquine. So don't think of laquinimod as just another hydroxychloroquine, because all of these side chains make a huge difference in the activity. This is our work showing giving laquinimod, comparing it to high-dose mycophenolate in a mouse model of nephritis. Here's proteinuria in the control. Here's low-dose mycophenolate, high-dose mycophenolate, and low and high-dose laquinimod. In the rise of the creatinine that occurs as the mice get sick, that was completely prevented by high-dose laquinimod, but not by the mycophenolate. And here is what this is the untreated mouse. Look at the large glomeruli with lots of immunoglobulin, lots of complement, and the largeness doesn't occur in animals on laquinimod or high-dose mycophenolate, and they don't get the deposits. We have treated mice with advanced disease, and laquinimod is quite effective in that group, more so than mycophenolate. Now finally, could we target the main problem for our patients that don't have nephritis with agents that work for that problem without flaring lupus in other organs? So here are the ideas we've all had, including you out there. Could we give abatacept or Rencia for arthritis? Could we give the anti-interferon alpha for dermatitis of lupus, since those skin lesions are so rich in interferon alpha? Could we do TNF inhibition for arthritis? And you know that's been tried, and so far it hasn't been perfected enough in terms of safety. Could we give rituximab for cytopenias and or antiphospholipid syndromes, and would it work better in the United States than it does for lupus nephritis? And can we give tocilizumab for arthritis and vasculitis? And as I teach in many places around the world, I find a lot of rheumatologists are using tocilizumab for lupus when they don't have anything else that they can do that works. And a lot of people who are thought leaders in their community thinks that there are many patients who respond. There's one study that showed some response, a lot of toxicity. The dose was higher than we use for RA, and it isn't in the past year, so I didn't include that study here. Finally, preventing damage. This is what should work, so I'm going to end on this slightly low note, in my opinion. This is vitamin D. So vitamin D binds the vitamin D receptor inside a cell and RUNX receptor, and together the complex binds to DNA, and it tells the DNA to transcribe certain proteins. Here are the results that all should work in lupus. Th1 cells are dampened. These pro-inflammatory cytokines all go down. Th17, very pro-inflammatory, goes down. Tregs go up in numbers and activity, and the NK-T cell goes up in a way that it should be able to kill some of the pathologic cells that are inducing lupus. So all of this should be good, and we should be able to give vitamin D to lupus and have an effect on the disease. You know that many patients with lupus have low vitamin D. Many people have low vitamin D. It's very controversial how high you should raise it, but let's say that you want a goal of, say, 20-ish, something like that. And most lupus patients are around 20, and you want to get them, say, 35, 40, something like that. So there have been attempts to do that, and I have to tell you that the two studies I have seen couldn't show any benefit of vitamin D replacement in patients that have lupus with regard to the disease activity of the lupus or their prednisone requirement. However, if you really want to get 25-hydroxy levels up to the 35 to 40 target range, you have to give a lot. And 400 to 800 units a day won't do it. We're talking about like 15,000 units once a week, or 30,000 for maybe 6 weeks, and then continue that once a month. We're talking about lots of vitamin D, more than has been given. So what has been done, which are safe attempts to raise vitamin D, doesn't work very well to raise the 25-hydroxy, and it hasn't affected lupus. So keep looking for that. For atherosclerosis, we had a complete discussion by Dr. Manzi, and my interpretation of that data is that steroids statins seem to reduce cardiovascular events in patients that have renal transplants who have lupus, but I'm not convinced that we've been able to show it in other patients. However, the cardiologists have studied it in cohorts that are 40 to 50,000 individuals, and we haven't done that in lupus. So I think it's an open question. So I remind you, on infection, there are several papers on immunizations in the past year, very nice papers. They say what other papers have said before. Immunizations are very unlikely to flare lupus, and they protect almost as well as in the general population. In general, the immune response is a little lower in lupus, and that's mostly because of the prednisolone doses. Hypertension, renal failure, reduced by treatment with ACE and ARB, very strong effects. Please use ACE or ARB if you can to manage hypertension in lupus, rather than the cheaper alternatives that have not been shown to be as good to protect the kidney. Bone loss is reduced by bisphosphonates in postmenopausal women on steroids. You have to add calcium and vitamin D if you're doing bisphosphonates. We have no data to inform us on women who are younger than postmenopausal, who are premenopausal, and you don't need to keep emailing me about what to do with that patient, because there aren't good safety data, and you just have to make up your own mind whether the bisphosphonate risk is worth it. Repleting vitamin D, I discussed, and atherosclerosis, I discussed, and controlling the active disease is probably the most effective way to try to prevent the atherosclerosis. I thank you very much.
we won't have time for questions, but I thank you so much for this clarifying overview. Thank you all for being here on a Sunday morning. And I don't think we would like to make one question,
Yeah.
because we are over time. Okay, go ahead.
Okay. Thank you very much, Bevra. In your very recent review on belimumab and SLE, you insinuated that a reasonable approach would be to treat with rituximab followed by BAFF blockade. Can you be more specific on that?
Well, this idea isn't mine, and a lot of people have had it, and Betty Diamond and David Wofsy are talking about it, and that is when we're all trying to figure out why rituximab didn't work in the LUNAR study and other rituximab studies as well as it has done in open trials. And so people were thinking maybe when you deplete a lot of B cells, as you do with rituximab, levels of bliss go very high. And maybe that brings up some of these early plasma cells and maybe some naive B cells and pushes them into making the antibodies again. So if when you deplete B cells with rituximab, you might follow with belimumab, then that would knock out this bliss response, and perhaps you'd see a better response to rituximab. So it's an interesting idea. I'm also interested in the combo of the mycophenolate and belimumab, whether that might be a better approach. There are a lot of ways we might use belimumab in combination. It was used in combination in both the BLISS 52 and BLISS 76 trials. So I suggested that, and I'm very honored you've already read it. It just came out on Thursday and Sunday. So.
Thank you.
Okay, thank you so much, Professor. Thank you.